Dr. Schaffner, this is the part where I think you're going to have to break out your pelvic model. And the reason is that a lot of us, really don't know pelvic anatomy, and especially our patients, they really don't study their pelvis because it's not the kind of muscle that they ever were trained to take care of until it's not working. And so, can you talk a little bit about how you evaluate the patient when they come in with urinary incontinence, and what are some of your first steps?
Absolutely. So, first thing off the bat, I ask if they've ever been to physical therapy and been to a clinic. And we take them into a private room. All conversations are taking place in a private room. And I can say with a fair amount of certainty, most appointments are an hour, and the first 30 minutes are just conversation. We need to get a grasp on those behavioral habits that the patient may have. How much water are they drinking? So we ask a bunch of questions about their urinary health, their bowel health, and their sexual function. And so that helps enable us to write goals for that meet the patient's needs. For example, I've asked plenty of patients, are you sexually active? And they tell me no. So their erectile dysfunction isn't even an issue for them. They were not sexually active before surgery, so it's not an issue. So it's things that we don't even need to go down that road because they aren't and they don't plan to be. But relative to bowel and urinary, we also know that if somebody has severe constipation, it's going to be real, and they've got incontinence after surgery, with prostate cancer management, that's going to be really hard. We got to get the bowel management under control first. And so we ask a lot of questions there. After we do that, we do go into an evaluation, and that depends on where the patient is in their time scale. If it's within 3 months of that prostatectomy, we're fairly hands off. We will do some external touching right around the perineum. And so I did bring my pelvis with me. My pelvis does not have skin though, and I'm going to try to not make myself disappear. But this is here's the sacrum. Whoop, I disappeared. There we go. So here's the sacrum up at the top here. There we go. And this is the pubic bone down at the bottom. And so we will have people undressed if they're comfortable. We keep this at their comfort level. So it may not happen on the first visit, but sometimes we'll just be touching right around the rectum here or around the anus to see if they actually can contract their pelvic floor. And so relative to hands-on evaluation, that is a big part of what we do. We make sure that their hips move appropriately. We make sure that they can use their back muscles. But a lot of the continence with pelvic floor is like what you mentioned earlier, was the pressure management. So if I ask somebody to do a Kegel, which is the layman's term for a pelvic floor contraction, if I can't see what's happening here at the rectum, I can very easily make a poor assumption that possibly they are contracting that pelvic floor up, and it should be retracting in towards the body. But if I can't see it, I don't know for sure. And I have had cases where patients were not comfortable doing that evaluation on the first day, but they were after they got to know us, and they actually were what we call valsalvating, or they were and bearing down, and they were pushing out, which is actually increasing their incontinence. So that is an important part of the evaluation, is making sure the person can do that pelvic floor, they can do the Kegel, they can contract those muscles up. And then from there, whatever else has to happen, we do breath work. We check to see how they're breathing, because the respiratory diaphragm opposes the pelvic floor diaphragm. So as we take a breath in, that respiratory diaphragm is going to put pressure on the abdomen. And if the pelvic floor is so rigid that it can't move, then it can actually increase their incontinence. So there has to be mobility so that as you take a breath in, that pelvic floor can descend and it can come back up. And then the abdominals from the front, same thing. You have to be able to create that pressure so that when somebody has to actually go to the bathroom, it's kind of like squeezing toothpaste. I hate to use that analogy, but it works really well. The pelvic floor is kind of the cap of the toothpaste. And if that cap is on too loose because the pelvic floor isn't strong enough, then as they breathe, or like Dr. Sandberg had mentioned earlier, they bend over, they cough, they sneeze, they laugh, they do anything that increases that intra-abdominal pressure, it'll cause the incontinence. So we evaluate all those motions, see how they're breathing. And interestingly enough, your pelvic floor is not that much more different than mine. They are very similar. So if I take that pelvic floor and flip it to the inside, what's inside the body cavity, most of these muscles are exactly the same. And so whether it's you or whether it's me, so relative to how to use that pelvic floor, they function very, very similarly. So I can have, relate to them relative to some of these issues. So, and find solutions that work.